Yes. Assalamualaikum warahmatullahi wabarakatuh. Peace and blessing be upon us all. Good morning, everyone. I'm Jusha Arshi. You can call me Jusha, and I'm in my third year undergraduate nursing school in Universitas Indonesia, and part of committee from NTC Nursing Training. And now here I am standing as master of ceremony for this seminar. And on behalf of the organizing committee, I would like to warmly welcome all of you to today's hybrid seminar on health financing and mental health equity. And this event is hosted by the Faculty of Nursing Universitas Indonesia and the Nursing Training Center, or NTC, in collaboration with STAN Indonesia and the University of Manchester. And before we begin our agenda today, I would like to kindly ask you all to stand up for Indonesia National Anthem. Indonesia Raya, please begin.
Kita akan lihat di peta kita. Ini yang terbaru, tahun 2025. Kalau perubahannya di sini kita lihat dari tahun 2015.
Thank you. Ladies and gentlemen, please be seated. It is always an inspiring moment to begin our day with Indonesia Raya, a reminder of the spirit and unity that bring us all together. With the same spirit, allow me now to share today's agenda so we may move forward with purpose and clarity. And on behalf of the entire academic community, it is my great privilege to extend the warmest welcome to our distinguished guests, especially the Honorable Professor Budiana Kuliat, Professor Herni Susanti, and Professor Hema Malini, and Dr. Sigit Mulyono. And we are truly honored to have with us today a panel of distinguished speakers from the University of Manchester. Dr. Asri Maharani as a lecturer, Division of Nursing, Midwifery, and Social Work. And Dr. Laura Anselmi, a senior lecturer, Division of Population Health, Health Services Research, and Primary Care. And Dr. John Gibson, as Research Fellow, Hope Group, Center for Primary Care. And it is our great pleasure to introduce today's moderator, Professor Herni Susanti, SKP MN PhD, as Professor of Mental Health Nursing at Universitas Indonesia. Professor Herni has long been involved in advancing mental health nursing education, clinical practices, and research in Indonesia. She is also one of the core researchers in the STAN Indonesia project and has actively contributed to the development of community based mental health programs. Today, she will guide us through this important discussion with her expertise and deep understanding of the field. To begin our seminar, let us now invite the chairperson of Nursing Training Center, Dr. Sigit Mulyono, to deliver the opening speech. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Yeah. On behalf uh, Profesor Dr. R.R. Tuti Sri Haryati, SKP Emas, as a Dean of Faculty of Nursing, University of Indonesia. Yeah, she is apologized that hopefully today she will come, but they have to open meeting as well in other moments. Yeah. To our honor speaker from the United Kingdom, respected colleagues, lecturers, students, staff, researcher, and all participants join us today, both on-site, online, or offline. On behalf of Nursing Training Center, I would like to sincerely thank Professor Heni Susanti, CEO, Principal Investigator of STANS Indonesia, who not only serve as the moderator today, but also played as pivotal role in initiating and realizing this collaborative seminar. Also, on behalf of Prof. Budi Anakriat, uh, she is a senior lecturer in my university since I have a student. um, Lastly, allow me to extend our special gratitude to our three distinguished speakers from University of Manchester. It's respecting different academic division and bringing diverse expertise. Dr. Laura Anselmi, is I'm not wrong to spell your name? Oh, thank you. Yeah, senior lecturer from Division of Population Health, Health Services, Research and Primary Healthcare. Dr. Asri Maharani, yeah, lecturer from Division of Nursing, Midwifery and Social Work, School of Health Science. Yeah, thank you, Ms. Hasrini. This is Indonesian, I think. Dr. John Gibson, research fellow from the Center for Primary Healthcare and Health Services Research, Hope Group, Health Organization and Policy and Economic. This is important for us, yeah, nursing and economic issue. It's great honor and pleasure for me to welcome you to this international seminar on health financing and mental health equity, held here at the Gedung Pasca Sarjana Faculty of Nursing Universitas Indonesia. This seminar is part of meaningful collaboration between the Nursing Training Center, NTC, and Research Consortium Sustainable Treatment and Anxiety and Depression in Indonesia. This is today a big issue in Indonesia, depression, anxiety, also suicide for a teenager. Also known as STAN Indonesia. It reflects NTC ongoing commitment to expanding internationally capacity building initiatives and also represent across cutting them activity within the broader STEM program coordinated by the Faculty of Nursing Universitas Indonesia. Furthermore, strengthening capacity of health financing and mental health equity is vital despite being a topic that is not yet commonly explored in our context. We must recognize that any health program we develop require an economic perspective as a foundation of strength so that it become not only effective but also equitable and accessible. Without sound of financial planning and awareness of health economic, even the most well-intentioned mental health initiative may fail to reach the communities who need the most. We hope today's session will spark meaningful discussion, further new collaboration. I hope we have a more new collaboration as well as my contact. I'm a community health nursing, uh, especially in teenager, and inspire practical solution to address mental health and financing challenges in our healthcare system. Um, okay, because today also I have a job to open this seminar. So I would like to say Bismillahirrahmanirrahim. The International Seminar Health Financing and Mental Health Equity is open. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Sigit Mulyono, as the chairperson of Nursing Training Center. And we are now moving on the main session of today's event. With great respect, we would like to hand over the session the Honorable Professor Herni Susanti, who will serve as the moderator. Professor, the floor is yours.
Thank you for the MC. Juju, I called her. Such a beautiful Juju this morning. We just talked to our college that Juju is just like Barbie. Okay, good morning, everyone. This is such an honor for me to standing here, or later on we'll be sitting down there to moderate a very important, very precious moment of a webinar. Okay. Now it's on? Yeah, okay. Entitled Health Financing and Mental Health Equity. This is a topic which is in health sector, especially in nursing, I would say, is still rare to be discussed. Most of the time, what we have discussed is about the healthcare, including how the services to the patient, the quality of the care, and then the type of the care. But this time, we would like to explore a little bit. It's only superficial, I would say, from the economic perspective, from our expert, and it's an honor to welcome our speakers from University of Manchester. The first speaker, as has introduced, is Dr. Asri Maharani. She would present earlier on the first, right? Yeah. Dr. Asri Maharani is an expert in epidemiology, and she's the best college of mine when I did my PhD in University of Manchester. And she will be presenting health inequalities in non-communicable disease and mental health in Indonesia. Quite general, but she will focus more in the presentation on some data related to what we call inequalities, with some statistics, some quantitative study. Dr. Asri is an expert in quantitative and also an expert in, I would say, in our language, otak-atik. What is otak-atik, Mbak? Yeah, to explore, to study about the secondary data analysis. She's one of our best diaspora from Indonesia. Where is it from? Malang, University of Brawijaya. Basically, she is a doctor, and then now she is as a lecturer at the University of Manchester. Without any further long, we would like to welcome Dr. Asli to present. Time is yours, Dr. Asli.
Thank you, Prof. Herni, for the brief, good introduction. Thank you, Prof. Herni, and then thank you also for Universitas Indonesia to invite us and having us today. So yeah, as has explained by Prof. Herni, today we would like to talk about health inequalities and non-communicable diseases and mental health in Indonesia. It not specific, I understand, for mental health. I also will explain about non-communicable diseases. Ah. Okay, yeah. So there, okay. Okay. Thank you. So for today, I will start the presentation with explaining about the burden of disease in Indonesia. And then we will follow with the overview of health inequalities and disease. And then it will followed by how is it in non-communicable diseases and mental health in Indonesia. And then we will then discuss about how climate change deepen the health inequalities and mental health in Indonesia. So yeah, for the start, as we know that in Indonesia, we have a population that is aging. And as a consequence of that, we have the double burden of diseases. And so we still have communicable diseases, but then we also have non-communicable diseases. And it accounts for more than 70% of death at this moment in Indonesia. And mostly it's due to the cardiovascular diseases and diabetes, which account for around 35% of the all mortality, respectively. That's why we have in Indonesia a lot of news at this moment. Let's see, for example, people having sports and then they died, and then people have some activities and then without knowing that they ill or something like that and died suddenly. So yeah, we have quite a lot of cardiovascular diseases as a silent killer in Indonesia. And among the risk factors of non-communicable diseases that we have, At this moment, we have high systolic blood pressure that is mostly apparent in Indonesia. Tobacco use, because we have 70% of males still smoking. And then dietary risk, we have now a lot of food and then fast food, and also high BMI and high blood glucose. And mental health is also similar. It's not different with the NCD. So mental health at this moment affects more than 900 million of individuals, with 1 among 8 people experiencing mental health problems worldwide. And 80% of them resides in the low and middle income countries, including Indonesia. And at this moment in Indonesia, WHO has measured that around 9 million of people in Indonesia, they suffered from depression and anxiety, making it more pronounced in the country. And then it come with a quite high cost and reach more than $6 billion in Indonesia only. Even worse, this burden affects people differently. Some people get it, some people not get it. That's why then we come into health inequalities. And what is health inequalities? Health inequalities is the difference of health status and health determinants among different population group. So in health inequalities, for example, some people, especially in lower income people, they have higher risk of having diabetes. This is one of the example that we give. And this is also increased hypertension in urban compared to the in rural. But we will see from our research next. And some people get depression, especially the one who are not working, for example. So some groups of the people, they have higher burden of disease compared to the other groups. This is not necessarily unjust. Some of the determinants we cannot change, for example, age and then sex, we could not change, but some of them we can change. That's why then we come into health inequities. It is important to difference between health inequality and health inequity. For some health inequalities, we know that some can be changed and some cannot. But for health inequities, it is actually avoidable. So if we make some changes, we can actually avoid the difference between groups. So, for example, there is a higher rates of mental health or heart disease in deprived area due to the lack access of the healthy food. If there is a policy to improve access for the healthy food, and then we can avoid it. So this is what we call health inequity. So we can actually avoid it, and we need to make sure that we have a good health policy to do that. And then what is then the social determinants of health? So the social determinant of health is our condition, the condition of how we born and then how we grow up and then live, work and age that may affect our health. That's why we can say that we will get older. It is unavoidable, but people getting older age differently. Some people still have healthy life during their older age, but some people are not. So that's why then we have the determinants of health here. They can include income and employment, education, housing and living environment, access to the healthcare, social supports is also affecting it. So if we have a good social support, and then usually we have a better health here. And then have we actually researched about the social determinants in non-communicable diseases and mental health in Indonesia? There is a systematic review actually published in 2017 and looking at how many studies in Indonesia looking at social determinants of NCDs. There is quite a lot of studies, but then mostly they are only affect or they only include age and sex. So most study in Indonesia, they only include age and sex. Less of them include other factors, including education, income, geographic area. So still very few studies on that. So more and more studies are required. So I can see here we have postgraduate students, we have students here. So if you would like to looking at social determinants of health, mental health including, this will be good if you also include more social determinants there, more factors there. Less and then fewer more looking at the factors of or the effects of area level determinants. So see, for example, if the person live near hospital or near puskesmas, primary healthcare, or near posyandu, whether they have a better health or not. This is still very few studies looking at that, and a very good opportunity for you to study. And then I would like to bring you into our paper, one of our paper looking at hypertension awareness, control, and treatment in Indonesia. This paper used IFLS 5. So yeah, Prof. Herni already mentioned about how I work with secondary data analysis. It is actually a very good opportunity because you do not need to collect the data. The data is there already. We have Riskesdas, we have Indonesian Health Surveys 2023. We have IFLS, which is longitudinal study, Indonesian Family Life Survey, which is longitudinal study. So we have quite a lot of secondary data. We have also recently BPJS data. And then BPJS data sample is also very good in examining the social determinants of health. And then for this paper, we use 2014 IFLS, and then we define hypertension, as you know, if the person have a high blood pressure. And then we consider the respondents to be aware if they go to the healthcare professionals. And then we consider the respondents to be treated if they receive a treatment from healthcare professionals. And finally, we consider them to be under control if they take antihypertensive medication and then the blood pressure is controlled, which means below 140 and 90. And then from the data, we can see here that almost 1/3 of Indonesian population is actually have hypertension. It's quite high prevalence. And then it is increased quite modestly in urban areas. But then the one that I would like to focus here is that the control rate is very low. So basically it's only 2% of them controlled. So most of them are still very high. And then in both rural and urban setting, in urban areas, the one that has lowest control group is in the poorest income. So the one who are poor and live in rural area are the most not getting treatment and not yet control for the hypertension. And looking deeper into the data, I'm not sure whether you can read it because the numbers is quite tiny here, the slides. But from all of those 30%, it's only 40% are aware that they have hypertension. So only 40% of our population that need treatment actually go to the medical services. And then from those, it's only 10% that are treated. So it is actually very common happen, right? Like me when I was practicing in rural area. So people come to me and then got hypertension medication, but once they take medication, feel better, and then they stop the medication. And then they come back again to me like 3 months later and say, oh, I have headache again. And then the blood pressure control is actually high again. So it's common in our population, and we need to make sure that people get it. And among them is actually the control rates is very low in people with low education. So people with low education. So if they have people who are like educated like primary care or less, they are less aware of their condition, and they less come to the medical services. And then wealth quintile is also strongly predictive. So we can see that the people who are poor, and then they are in the lower quintiles, wealth quintiles, they are less go to the primary care, and also less have less medication. Interestingly, the older people, they have higher odds of receiving treatment if they have the condition compared to the younger people. So they are more aware of their condition, and females are more likely than males to go to the healthcare services. I think we have quite a lot of papa here, and we can ask, why don't you actually want to go to the medical services? And when they have a condition. I did ask actually several times, and then they say that, oh, we are afraid to know if we have a disease, we are afraid to know that we have a disease, because we work for the family. So we are the backbone of the family, and we don't want to like look ill or sick. And then that's one of the reasons. But yeah, I think we can reflect on this one. And then we do also another study in Malang district, and then we combine the data from e-Puskesmas. I think you are very aware with e-Puskesmas already. We can actually get the data from e-Puskesmas, and we combine the data with from e-Puskesmas and screening by community health workers or cadre. So we combine both data, and then we can then get a screening of almost 1 million people in Malang district only. So from this data, we screen people with the high cardiovascular risk, which is we based on the WHO CIRP. Yeah. Sorry. And then from the I'm sorry, it's a bit difficult to run this. Okay, so from our data, 18% of the population age 40 years and older in Indonesia, they have high cardiovascular risk, without their knowing that they have high cardiovascular risk. That's why we have quite a lot of silent killer in Indonesia. And surprisingly, and the proportion is almost similar in urban and rural areas, which means that even in rural areas now we have this challenge, not only in urban areas. And then among them, we can see here that among the risk factors, we have the people with the again with the low socioeconomic condition, and then the people with low education, they have actually higher risk of having the CVD risk. And being unemployed is also working in informal sector, so we need to be very careful with this one, is also have a higher risk of cardiovascular diseases. So those people who are actually, I don't know, working outside, selling food and everything else, they have actually higher risk of cardiovascular disease also. And having BPJS or health insurance, and also living in rural areas is still associated with lower CVD risk, although we have already a high risk. But then we have also in Indonesia another challenge, which is we have unequal distribution of hospitals and physicians in Indonesia. So, and as we can see in our map, this is also one that I like to work with the data, working with the map, because we have 17,000 islands. So the maps looks quite nice actually. But then we have here space distribution of unequal distribution of hospital in Indonesia. So almost half of the district in Indonesia, so I understand that we now have 514 district, almost half, around 200 district, they have only one hospital. And then only 6 district, including Jakarta probably, have more than 20 hospital. So it is very unequal. Some district have 1, some district have more than 20. Physicians are all also the same. So we can see that 11 districts, including Jakarta, have more 1,000 of physicians. while in the other district, including in Papua and in east of Indonesia, they have only less than 10 physicians. So yeah, this inequality then make it worse, and then we can see here, then we analyze the data whether then it affects the health inequality in Indonesia, and we can see here that higher availability of Pospindu have community health posts is actually associated with the lower CVD risk. So we actually can say that cadres have important roles in prevention and health promotion in Indonesia. Nurse is also the same. So we found that the greater of nurse density is also reduce the CVD risk in Indonesia. And then how about the inequality in mental health? Because yeah, mental health is one of the high burden also in Indonesia. Then we do some analysis using risk assess data in 2018. And then we include only those 18 plus from risk assess data. And in the data, depression was measured by MINI. And then we also include the data on density of medical doctor, density of psychiatrists, density of hospital using RISFASCUS or Health Facility Survey in 2019 and RISNACUS Human Resource Survey in 2017 and GDP and happiness index. And we use multi-level modeling to look at the impact of individual and area level determinants to the depression in Indonesia. The paper will be published soon, and we will let you know so you can look at it in details. So this is the inequality in depression in Indonesia. So from 600,000 participants, 6% of them have depression as measured by MINI. And then there is also geographical variation in depression in Indonesia. So if you can see there, the one that with the higher proportion is the one who live in Java coastlines. So it is in the beach area in Java, and then Sumatra, North Sumatra, West Sumatra, and also South Sumatra. Another part that is quite high is in the southern Papua and the small island of Maluku. So it is very, very concerning because in those areas, I think that they have less psychiatrists and psychologists and mental health nurse over there. And then we can see here that what is affecting people with depression. So we can see that lower education is strongly associated with the higher odds of depression here. And then also occupation matters. The student is actually have more depression too, because we have quite a lot of students here. Okay. And then marital status is protective for depression. Those who are married, they are less depressed. And economic status is also strong determinants of depression. With the people who are less wealthy, they have higher odds of having depression. Is access to healthcare matters for mental health? What we found here that the individuals or those who find the reported difficult access to healthcare, they have higher odds of depression. However, we have not found that the facilities availability is associated with depression here. So if you find it further for mental health care services or healthcare services, and then you are in higher risk of depression here. And then we then look at the climate change because Indonesia is now, we are archipelago and we have a lot of sea level rise here. Like what we call in Indonesia is kenaikan air laut. Yeah, sea level rise. So a lot of area are actually under the sea at this moment. And then we would like to see how then it's related to depression in Indonesia. We use the same data from Riskesdas, but we connect it with PODES or village survey. So this is also a good thing from secondary data analysis, that you can connect the data between Riskesdas, Rifaskas, PODES, and other data sources. And then from the PODES, we can see here that in the this is the coastal area that affected by sea level rise here, including the Sumatra coastline, West Sumatra coastline, Sulawesi, Papua, and some on the Java coastline also. It's very have a very high number of abrasion, hurricanes, and tidal floods here. And from our analysis, people who live in the area with the coastal hazard, they have actually higher odds of having depression, including if they have a lot of flood, and then they have experienced a lot of hurricanes, is also the same. They have a higher chance of having depression here. And when we look at its more more details here, and then those people who are affected by coastal hazard, they also have higher depression here. So the red one is the people that are affecting by coastal hazard, and the blue one is not. So we can see even in different quintiles, wealth quintiles, they still have higher risk. And the risk is bigger when they are in the lowest quintile of wealth. So the poorest and living in the coastline area is the one are most affected by climate change. Yeah, so I think this is the last slide, and we can see here that the climate change is actually deepen the risk of being depression, or deepen the health inequality and mental health in Indonesia. And thus we need to start thinking about how we can address these changes, because we cannot avoid it. The climate is already changed, and then we need to make sure that we take good steps to protect the people from mental health, especially those who affected by the climate change. I think, thank you, and I give it back to Prof. Herni.
Thank you, Dr. Asri, for a very I would say very important information, enlightening information, sources from big data, yeah, for national, and then that's also give us understanding how the physical illness, especially Dr. Asli focused on the CVD, the cardiovascular disease, on mental health. Thank you. And then I will also greet to our audience online. Hello, everyone online. I hope you are now enjoying the seminar. Yeah. How many thousands the audience? 5,000.
Might be 20,000.
Thank you for the audience. And also, we would like to extend our gratitude for those who are already coming here. At the back, we are seeing Professor Agung. Would you like to come forward, Professor Agung, to become our honorable audience as well? Professor Agung Walio is our professor in the faculty, and he is from medical. I delivered by Dr. Asri is one with his expertise as well. He is also an expert in cancer or oncology. So thank you for coming. Okay, so we will welcome to the further or the next speaker. That would be Laura, right? I forgot to bring my card, Laura. Sorry. It's Dr. Laura Anselmi, as a senior lecturer from Division of Population Health, Health Services Research and Primary Care. And the topic is about equity and efficiency in health resource allocation and provider payment. For your information, Dr. Laura is a very expert in health. She is one of the contributing reviewer in our just recent Congress, the World Congress, Health Economic Congress. So it's very honor Laura and Selmi can visit in our modest campus. Thank you, Laura, and share your expertise. Time is yours. Thank you.
Thank you, Professor Annie, for the introduction, and thank you everyone for being here with us and inviting us. Have I got the slides? I think we are now going to move away a little bit from health itself and start thinking a bit more about the financing and the allocation of resources in order to make access to service equitable and efficient. And whenever possible, I'll try to focus a little bit on examples related to mental health. Unlike the presentation from Hazel, I think we won't have that many data, but I think I'll try to go through some of the concepts. Let me see if I can. Okay, yes, that's great. I will introduce some concepts related to resource allocation, and I will talk in particular about funding formula, which are an important tool to try and help us in where we should allocate more or less resources based on the needs of the population that are being served. And for this, I will draw on a chapter from a book that is focused on financing in low and middle income country that is going to be published and available online, open access very soon. I will also give an example of some work that I was involved with in determining the formula for resource allocation for mental health services in England, which is one quite developed example, because England is one of those settings that has a long history of use of resource allocation formula. And then I will also draw on some work that's been led by John, but it's also in collaboration with all the colleagues in the STAND project to try and look at use some of those tools from resource allocation to try and establish some benchmark for the distribution of resources that are not financial, but are more workforce and staff. So, yes, moving. Oh. Yes, I just wanted to, oh, okay. So just to set up the scene, I think that it's important to remind that overall the objective of resource allocation is to promote population health and improvements of population health, and do that in a way that improves efficiency and equity within the system. And typically the way to do that is to make sure that the resources are distributed in a way that match needs. So there are more resources where the needs are higher. I'm an economist by background, and economists tend to think of the investments of resources as an input into the production of health. So they're not the ultimate objective, but the allocation of resources is functional to achieve those health improvement. And we are also all very aware that resources are overall scarce everywhere, and there are difficult decisions to make. And governments in particular have decisions to make about how to distribute their funding in relation to health services. And there are typically three types of decisions that governments have to make. And those are which services have to be funded. So do we need to fund mental health services, and which type of services, for whom, so for which type of population, given that we have scarce resources, do we want to prioritize younger, older, or population in certain areas, population that appear to have more higher prevalence or more severe condition. And the third decision is how. So it's about in which way to do that. And there are different tools for different types of decisions that should be taken in terms of distributing budgets. There's a couple of concepts that I think I will be touching across the presentation, and I thought it's worth clarifying. And the first one is that we refer to health expenditure as funding or resources that have actually been spent or used. And this is different from budgets that are the resources that an area or a provider is entitled to have. But that does not necessarily mean that they will be able to use those resources in a certain way. We'll see the Next, I wanted to contextualize government decision about resource allocation within the flow of funding in the health system. And this slide basically shows you how essentially all resources initially come from citizens and service users. And those resources can be gathered and pooled at the level of the national government or at the level of local government through taxes and through the contribution that all of us make towards the government, or they can be pooled and collected directly at the level of service provider. And this is the case when we pay fees directly to provider. When there is pooling at the level of national or local government, then there are also decisions that those governments need to be made in terms of how to allocate resources. And these are highlighted in the lighter gray arrows. And this shows that basically national government have the task to decide how many resources to allocate either to local government or directly to service provider. And in some settings, in some countries, there are also international donors that play a role within this and distribute resources either directly to the government, leaving the government free to take all of those decisions, or they can decide to fund local government or provider directly, and they will have to take those decisions. Now, funding formula have been used across different settings as a way to inform the distribution of budget to subnational units in order to enable service delivery, or in some cases directly to provider. And there are three key components to this, and to this formula. And these three components are the population share. So typically capitation is a key component and a key determinant of the distribution of funding. We need to know how many people are to be served. The second component is some weights that are reflecting the resource requirements or the service needs for the different types of population in the different units to which we are allocating funding. And typically there's also a third component in practice that is meant to account for differences in costs that might be faced across different areas. And we're not going to focus that much on that part today. Those formula are typically used to identify what are the equitable or fair share of a limited budget to be distributed across those units, being, again, local governments or provided more typically. And how they are shaped in practice varies across settings and across the strategic objective of a given health service and what they want to prioritize and what is important to them to wait for. And there are typically some practical issues, both in the design and the implementation. And when it comes to the design, one of the key practical issue is how to measure and define need, and also how to measure or define the use of services. And I'll touch upon this a bit later. There's also some decision that needs to be made about which services are to be funded and considered for the distribution. So again, we might not be able to provide the entire set of services to everyone in every health facility, but we might decide to focus only on certain defined services. And one of the things that in theory should probably not be done at the stage of the design when we try to get our best measure of need is get stuck into understanding which specific region or which specific provinces gain or lose. But this will always happen in practice, and there's always needs to be a bit of a sense check of whether the analysis that is being done reflect the reality or the expectation. When it comes to the implementation, one of the things that has been noticed and might seem obvious is that it's very difficult to redistribute existing resources by taking away from some units or some population to give more to others. So the approach that has been taken in practice is essentially to redistribute progressively, increasing budget in a way that help to reach the equitable target. So this also means that in practice, we can implement some of those tools only when we have an increasing budget and increasing resources to distribute. Although measuring needs might be very tricky and there might be very sophisticated measure to do that, we also need to balance with the trade-off of having something that is more intuitive and more understandable by anyone that might be involved in the process and might be need to use that. So in some cases, we might need to give up a little bit on precision to have something that is more widely understood and accepted. And obviously there needs to be an engagement with all the stakeholders involved in the process at a different level. So formulae have been used in different settings, and one of the example is, for example, in payments for primary care in Indonesia. I'm not the expert here, and I'm reporting some information, but I'm sure that some of you will know much more of the details. But there was a decentralization that took place in 2001 that gave more responsibility to primary care provider and more autonomy, and also more space for direct payments. With the introduction of the National Health Insurance Scheme in 2014, there was a bit of a change in the way in which primary care providers were paid. So the budget was not coming directly from the Ministry of Health, but was coming from the Ministry of Finance directly into, yeah, is it better? Okay. Directly into the bank account of the primary care provider. And those payments from the Ministry of Finance have been progressively replaced by payment coming from the National Health Insurance. And those typically come in two ways. One way which is capitation based, and one way which is based on fees and reimbursement. And the capitation, the part which is capitation based is informed by the number of population, by age and gender, but also by the availability of doctor, the availability and condition of medical equipments, and there are also some adjustment for remoteness. So this is an example of a resource allocation formula which is used in practice in Indonesia. And it's important to note that those type of formulae are always implemented alongside other types of payments. The other example that I wanted to give is for mental health care in England. In England, there are about 60 million patients. Everyone is registered with a general practitioner, and mental health is provided in primary, secondary, and tertiary care. Secondary care is provided and commissioned by local organizations that have changed their name and shape over time. And those organizations typically receive a budget from the National Health Service centrally. And those budgets for secondary services that are allocated centrally to different local organizations, which are now called Integrated Care Board, are allocated based on a set of formulae. Those have been developed since 1970s in different ways and have been more and more sophisticated. And they're now composed essentially of a set of weights for different type of services. So for example, for hospital care, for prescribing, but also for mental health in particular. And those weights are meant to capture the differences in relative needs for the services that are to be commissioned and provided at the local level. And so I wanted to just say a little bit about how that formula for mental health services has been developed over time. It was for the first time introduced in the NHS in 1996, and that was based on some area level data that has been progressively developed and refreshed over time. And the last time it was refreshed in 2019-20. And that exercise was based on using data for every single patient registered with a general practice, so 60 million patients, making use of all information on all the services that they've used, and all the different patients' characteristics that might reflect differences in need, as well as the access to services that the patients might have. And need was then estimated as the predicted service use of all those different types of services, which were summarized with a measure of total cost for mental health care services, as predicted, as if those predictions depended only on patients' characteristics reflecting need, but not taking into account the differences in access to services. And this was done through some econometric exercise. But we could take into account quite a rich set of information here. So we consider services in terms of talking therapy, in terms of secondary care outpatient contacts, and inpatient admission to hospital. As indicator of need, we could use information on age, gender, ethnicity, the household type where the individual resides, whether the individual had already been in touch for some mental health care in the past, whether the individual had a specific set of physical health diagnoses recorded during contacts with hospital services, and those were diagnoses well known to be correlated with mental health, and whether the patient was in some general practices that had higher prevalence of mental health. We also took into account some information on access to services as captured by the distance to a mental health hospital and by the different commissioners that were serving those population, and those factors were taken out. And we were then able to derive some indices that varied around 1, where 1 indicate the average national need, and an index higher than 1 indicates essentially a need which is higher than average, or lower than 1, lower than average. And you could think of an index of 1.02 as a 2 percentage point need higher than the national average. And those indices were used to weight the population across different areas and redistribute the budget accordingly. Another example that I wanted to briefly touch on is the distribution of the health workforce. So in many countries, there are long-term plan that sets some targets for the increase of staff, and this is also the case on Indonesia. There's no specific guideline on the number of mental health staff that should be available in different districts and different areas. And so what we did is that we tried to link some information on the availability of psychologists and psychiatrists across different districts with the characteristics of the population at the local area, including mental health prevalence and some indicators of need, and try to then see how resources were distributed in different ways, either based on an equal per capita allocation, where we wouldn't take into account differences in need, or how they were distributed compared to a benchmark that would take into account not only how many people were in different districts, but the different prevalence of mental health that would be on those different districts. So that would be a need-weighted distribution of resources. And we did that considering a redistribution of the current number of staff. So there was no expansion, but just a redistribution of the available staff, and taking into account the possibility of expanding the number of workforce up to some standard determined by WHO. That would be of 3.3 psychiatrists and 10 clinical psychologists per 100,000 patients. I'm almost done. I just wanted to show you again some map that Azri has already shown, so there shouldn't really be anything completely new. The only thing is that you can see the differences in depression of prevalence, and also the differences in the distribution of psychiatrists and psychologists across districts. And we can see immediately that they don't always necessarily match. So there's a little bit of number here, and we don't go through all of them. But the thing to point out is that both when we look up psychiatrists or psychologists, if we take into account just a benchmark, which is the redistribution of the current workforce in a way that does the same number of psychiatrists and psychologists across districts per 100,000 population. We find that about 70% of the districts have a number of staff which is lower compared to the average if we were to redistribute in an equal way by population the current resources. And we can also see that if we were to use a benchmark that was slightly different and accounted for the difference in prevalence, then we would find a slightly higher number of districts, 8%, that would have a lower number of psychiatrists or psychologists than expected. And this is essentially an indication that the current available resources are distributed more based on population, but not as much as accounting for different in prevalence. And the trend would be similar if we were to use a benchmark that was expansive and we were to think of a dream scenario where we could have the ideal number of psychologists and psychiatrists. So this is all work in progress, and there's not much detail here, but it's just to show that those tools can also be used to benchmark the distribution not only on funding, but also of staff, and to give us some indication of where we might want to concentrate resources. Of course, in practice, this always also depends on how the services are constructed and how the services are available on the ground. And I think I'll conclude here and leave the floor to the next speaker. Thank you.
Thank you, Laura. This was a very interesting presentation as well that emphasized the issue of inequality of service, especially you compared England and Indonesia. As Laura also mentioned, Prabhuti here, Prabhuti really have a very critical question or comments. Just be prepared, the speakers. But I also invite all of the audience to prepare the questions, or also perhaps update some data presented by our speakers. Please welcome. Do not worry about the language. If you want to deliver in Bahasa, that's okay. I can help you with, yeah. Just prepare the question from now on so we can have discussions, Q&A session after the whole speaker finish, yeah. So we will welcome our last but not the least speaker, the only gentleman from those speakers, Dr. John Gibson, as the research fellow from the health organization and also in the policy and economic group. John will deliver a topic about mental health and loss productivity in Indonesia. Welcome, John.
Okay. Thank you for the introduction. And yes, this is preliminary work, so it's work in progress. So questions are very much welcome. Any comments, any way that you think we can improve the research that we're doing here will be really welcome. So just like the data that Laura has just presented, this is also work in progress. So yeah. Whereas Azri and Laura were presenting analysis on inequalities in the prevalence of illness and in the distribution of health services, I'm going to be talking about the outcomes of poor health and poor mental health in particular. I'm a health economist, an economist, and so what we're going to be looking at in terms of outcomes is job outcomes. So how does poor mental health affect people in different job roles differently? So we've got data from our STAND project that we're going to be examining, and we're going to be presenting how poor mental health affects people in different job roles differently. And this is kind of important because we can observe these differences. We can look at the differences in job types, and we can think maybe how we can improve or support people in highly affected job roles. So that's quite important for policy. Okay. Okay, so we can think about how inequalities affect the prevalence of poor mental health. So we can think about the different levels of education that people get, the occupation types. There are different types of jobs that people have. Some jobs might be more manually intensive. Some jobs might be insecure, so you're at risk of losing your job, which gives you high stress and worry. And can lead to poor mental health. Associated with your job, you can have different levels of income. So again, that's likely to affect your mental health. So if you've got high income, that might give you more flexibility, more financial security. So within job roles as well, there's different workplace environments. So some workplaces can be more or less supportive, and this can affect your level of presenteeism or absenteeism. And those are the particular job outcomes that I'll be looking at today. And of course, the access to health services as well that you might have. So these are all examples of sort of the inequalities that we're interested in. Okay. Down. Okay. Okay, so why this matters. So as we've heard from the other presenters as well, depression and anxiety are large causes of disability, and they can reduce productivity. So we're interested here in productivity via absenteeism and presenteeism. So what we mean by absenteeism is if you're feeling unwell, either physically or mentally, you're going to take time, you maybe take time off work. You may not go to work because of your illness. Presenteeism, on the other hand, is if you've got a poor health, physical or mental, you attend work despite that illness. So you're still attending work. And we're particularly interested in, for this research, dysfunctional presenteeism. So that's where you attend work, but you achieve less. So you're ill, you're unwell, with poor mental health in this case. You're attending work, but you're achieving less. And this is a productivity loss to the economy. You're getting less done, and poor mental health affects the economy in this way. We know from work in the United States that depression-linked work loss contributes to sort of a $36 billion loss per year in the United States. However, there are relatively few studies in lower or middle-income countries that look at this, and very, very minimal studies that look at the differences between different job types, which we've been looking at here. And that's, in effect, a bit of a blind spot. And we know that all these different aspects of your job, mental health may have different effects across these jobs. Okay, so particularly this might be the case for informal jobs where you don't have high job security. That might affect your ability to take time off work if you're ill. So if you have an inflexible, informal job, you might feel pressurized to attend work even though you are perhaps ill. Okay, so mental health can affect your employment, your job in many ways. Sorry if this is a bit small, but you can lose your job entirely, perhaps. So if you have poor mental health, poor physical health, and you're not getting a lot done on the job, you may lose your employment. You may decide that your job is quite strenuous, and given your disabilities, you can't contribute to that job as effectively. So you may reduce your working hours, which reduces your income as well. You may just find that your income is reduced, you have reduced earnings, and that might be through discrimination, or that might be because of the reduction in hours. You may find that you're less productive at work, which is kind of the area that we're going to be discussing today. And this might affect your ability to get promotion at work. So again, that's linked to pay. And then the two areas that I'm going to be looking at are presenteeism, which is attending work whilst ill, and absenteeism, which is whilst ill taking time off work. Or you may be suffering so much ill health that you leave the labor market entirely. So that's, you lose your job and you're not actively looking for another job as well. So you've just retired, or you're completely out of the labor market. Okay, so for presenteeism, which is attending work while ill health, there is a different different forms of presenteeism. We're particularly interested in dysfunctional presenteeism, which is that bottom left quadrant of the square here, and that represents someone who's got poor health and poor productivity at work. So they're attending work whilst ill, and they're achieving less. So this is the productivity loss that we're interested in. And we're interested in how this differs between the different types of jobs that people have in Indonesia. Okay. Okay, so our framework, oh, maybe, think of, 1 second. There is a slide coming. Okay, here we go. So we're interested in these two outcomes: absenteeism and presenteeism. So absenteeism again is where you don't attend work despite your ill health, and we believe that that's going to differ by job role. So some jobs, people in some certain jobs might find it easier to take time off work when they're ill health. And then presenteeism is kind of the opposite of that. You're suffering from ill health, but you're attending work anyway. You don't feel like you can take time off, so you're attending work and perhaps getting less done. So these are kind of substitutes in a way, and kind of how do they interact? And so there's been some research done looking at the effect of taking time off work. Does those short periods of time off work improve your mental health and then maybe reduce the presenteeism, so increase the amount of work that you can get done in the future? And so there's a whole body of work which looks at whether this is a good thing or not. Is taking time off work a good thing? And a lot of the literature seems to suggest it is, and it reduces long-term productivity losses. Okay, so our framework is to look at somebody who is suffering from poor mental health or physical health and look at their decision making. So they have a decision to make. Do they attend work or do they not attend work? If they do not attend work, we think that that might be affected by various characteristics of their job. Do they have any paid sick leave available to them? So they in a formal job where they have a contract where if they don't turn up to work, they'll still get paid. Do they have a supportive human resources department that have policies in place that will support them and encourage them to take time off work if they're ill? Or do they have unions or access to healthcare as part of their job? If they don't attend work, then that is presenteeism, and that might be associated with the same kind of characteristics of their job. They don't have access. They might not have access to paid sick leave. They might have an insecure job. They might have a heavy workload, which is kind of pressurizing them to attend work. Okay, so our study aims are to assess the link between mental health symptoms and work loss in Indonesian workers. And our outcomes that we're going to be looking at are these two that I've just discussed: absenteeism, which is people not attending work, and then presenteeism, so dysfunctional presenteeism, so people attending work and getting less done. So these are the two outcomes that we're interested in this study. We're interested in examining the relationship between these outcomes and mental health in respondents from 3 employment types: those people who are self-employed, those people who are private workers or work for the government, and people who are casual laborers. So these are very different kind of job types. They have different kind of contracts and abilities to take time off work. And so we're interested in how their mental health kind of affects their ability to take time off or get less done. And so our hypothesis is that relative to government workers, the casual workers and the self-employed people in our sample are likely to take less time off work, so that the absenteeism rates are probably lower. But on the flip side of that, they're probably attending work while in ill health, which is not so good for their productivity. So they're probably attending work when they shouldn't and achieving less. So that's our hypothesis for this research. Okay. In the interest of time, I'm gonna go through these next slides pretty quickly. So this is work we're doing as part of the STAND project, Sustainable Treatment of Anxiety and Depression. This is primary data that we're using that was collected at 12 sites across 3 provinces, and they're shown on this map here. And we'll skip that. So the data setting is the STAND household survey that was collected in 2023. We have 12 villages, And the sample that I'm going to be using is from about 9,800 people. And these are distributed across these self-employed government workers and casual workers. And we're going to be looking at their mental health symptoms using the CESD-10 measure for depression symptoms and the GAD-7 measure for anxiety symptoms. So for each of these 9,000 people, we know what type of job they have and what their mental health symptoms are. We also have a measure of achieving less at work, which is from the SF-12 instrument. So these are kind of the instruments that we have that will allow us to answer our research question. We're going to be looking at absenteeism and presenteeism. So for absenteeism, we had a very basic question in our survey. We simply asked people, during the last 4 weeks, how many days of work at education did you miss due to poor mental health or physical health? So we know for each person in our sample how many days they had to take off work or education. So what we do is we create a binary variable which takes the value 1 if they missed any work, or a value 0 if they didn't miss any work. We also have a binary indicator for presenteeism, which comes from this SF-12 measure. So we have 5 questions which ask them about, did having ill health limit you in some way in the amount of work that you could get done? And so we use these 5 questions to then create a binary variable. So if someone has got presenteeism, so getting less done at work. Okay, so what we then have is our categories of job roles. We have people who are employed in the private sector or in government, people who are self-employed, and people who are casual workers. And these come from these different outcomes in our survey. So there are a much broader range of job roles, and we've just kind of condensed them down into these 3 different groups. And for the purposes of this research, we've removed people who are unemployed or students or housewives from our sample, because we're only interested in those who are in earning incomes in their job. Okay, so we have our symptom measures, which are CSD-10 and GAD-7. These tell us how much depressive or anxiety symptoms our respondents have. We have our outcomes, so we know whether our respondents are suffering from absenteeism or presenteeism. And then what we do is we basically model that using a bivariate probit, which has an interaction term in there between their mental health and employment. And that allows us to do some modeling, which I'll present in the next slide. And then we also adjust these models for age, sex, education, health, income, and these province fixed effects as well. So I will get through, present the sample. So the sample, we have these 3 groups of workers. So for our self-employed workers, we know that about 8% of those in the self-employed group have got some level of absenteeism, whereas in our government workers, private workers, about 10% have got absenteeism. So that kind of already starts to address our research question, and our hypothesis is that these government workers are potentially more secure in their jobs, have access to sick leave, and therefore are more likely to present with absenteeism. And on the flip side of that, then these workers have got, these government and private workers suffer less from presenteeism as well. So when they are attending work, they're not getting less done. Okay, so just hopefully you can see that. Just to our model outcomes, what do we find? Well, pretty much confirming what we see in the raw data. We see, so what these graphs are is along the bottom axis, we have our depression symptoms. And on our side axis, we have our probability of the respondent having presenteeism and absenteeism on the left-hand side, presenteeism only or absenteeism only. So what we see in that first graph is that the green line is for casual workers, and for all depression symptom scores, these workers are experiencing more presenteeism, absenteeism relative to the government and self-employed workers. And the government workers are showing, again, for all levels of the CESD depression symptoms, higher rates of absenteeism on the graph on the very right as well. So we are seeing these differences in people, these inequalities for people with different types of jobs and the different outcomes that poor mental health is having for these different types of workers. Okay, and we can do exactly the same thing for anxiety symptoms, and we find the same pattern. So even after adjusting for all the different factors that make these people different, the different levels of education, age, gender, etc., we find that government and private workers have got higher rates of absenteeism and lower rates of presenteeism across the entire distribution of our mental health symptom scores. And then we can do some more statistical tests to confirm whether the differences between our lines on our graphs are statistically significant. I won't go into details due to time, but basically we do find significant differences between the different outcomes for these different types of workers. So we test that in a number of ways, which I can give you more details on later, but we find differences in outcomes. So what does that mean? Well, we find that employment type differences impact the association between mental health symptoms and work loss through absenteeism or presenteeism. And in particular, casual laborers appear most vulnerable for anxiety-linked presenteeism. And we also find that the government workers have got more likely to take time off work through absenteeism. However, what we're using to examine this research question is cross-sectional data. So we're always concerned about reverse causality. Are people with perhaps poorer mental health entering into different job roles? We only have currently employed adults in our sample for the time being. We've excluded anyone who might have quit work due to ill health, unfortunately. And yeah, our symptom measures and work loss are self-reported as well. However, we are continuing to work on STAND. We have got a next wave of data collection, which is going to help us perhaps do some panel data analysis, which will help us control for those time invariant effects. And we're going to be able to update our analysis with in-person changes into their symptoms or rates of absenteeism. So yep, that is the end of my presentation. So thank you for listening.
Yeah. Thank you, John, for the presentation. So all presenters have completed the slide, and now we're going to have the discussion session. And we would like to invite everyone to go upstairs, and then
Pak Eka besok ke sana kan? Hari Jumat ya?
All right. So from today's presentation, we learned a lot of things. Starting from what is inequality, the difference with inequity, and also this issue discussed
Cuman itu
in
saya bingungnya,
context.
saya belum pernah
in
dapat
the
laporan
context.
sama saja masuk ya.
You just make sure it's mute. Okay. And the last one is about presenteeism or absenteeism. That is a very, I would say, interesting topic that correlate not only in mental health. I've just discussed a little bit with Prof. Agung that might also relate to any other health condition, like patient with cancer, the one that can be underexplored in our context. But anyway, I will invite you to discuss more within the next 30 minutes with our expert here. I will invite 3 questions first. From this room and also maybe from the Zoom, yeah. But I don't know how I can access the Zoom. Is there any way how I can get information whether there Zoom one? Okay, first from this room. Okay, one, and then. No, you can. You have the privilege even for the first ones. Okay, 1, 2, and 3 at from the front. Yeah. Okay, please.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, everyone. Thank you for the inspiring and insightful presentation. My name is Vika, and I'm a registered nurse from Indonesia and currently working in the operating room in one of the government hospital in Jakarta. I also want to say thank you so much for Nursing Training Center UI for organizing such a great and valuable event. But firstly, I know my question may be slightly different from today's main topic, but I truly hope that meeting all of you as experts in mental health nursing can give me new insight and perspective. Actually, I'm currently planning to pursue my master degree and still deciding between mental health nursing and forensic nursing. The hospital where I work is developing a clinical forensic program, but it's still not running optimally due to a lack of trained professionals. Some colleges recommend starting with mental health nursing as a strong foundation that can connect to forensic care later, while others suggest going directly into forensic nursing. The challenge is I don't have any experience in either field yet.
And then the question?
And then I'm also interested in studying abroad, especially because the role of forensic nurses is not really formal established in Indonesia. I hope to contribute to that development in the future. So, in your opinion, which path would offer better long-term opportunities and relevance? And how can I best align my studies with that goal? Additionally, could you kindly share any suggestions for universities that offer scholarship for these programs and how competitive and accessible these opportunities are for international nurses? Thank you very much for your kind advice. Your insight will be extremely helpful as I try to make the best possible decision for my academic and professional future. Thank you.
Thank you, Vika, for the question. I will go on for the next questions. Yeah. The next question would be Angga. Yeah. Okay.
Good morning, everyone. My name is Angga Mete. You can call me Angga. The first, I want to say thank you to the presentation. I think this presentation is to more detail about mental health financing and financing and mental health equity. And my question is, if we talk about equity, health equity in Indonesia, there is there are between on East Indonesian and West Indonesian. I'm from East Indonesian and work in public in primary healthcare. I was work in Puskesmas, and I know in East Indonesia we have we don't have more access to like maybe in Asia we it's hard to apa to gathering nursing or health worker others to give health promotion about no, about um, cardiac disease, hypertension, and agak nurses. Oke, jadi di Indonesia Timur itu sangat sulit bahkan untuk memberikan promosi kesehatan saja itu sangat sulit. Apalagi kita bicara tentang mungkin alat peralatan untuk mengatasi hipertensi, kemudian penyakit jantung lainnya, apalagi bicara tentang mental health karena sejujurnya mental health itu menurut mereka bukan suatu penyakit. Mental health itu adalah seperti kutukan, curse, adat istiadat yang mungkin ini akibat kesalahan dari masa lalu. Jadi edukasi itu sangat sangat berpengaruh. Seperti tadi yang Dr. Asri presentasikan bahwa memang level edukasi yang rendah itu punya dampak yang besar terhadap pengertian pemahaman masyarakat dan bagaimana mereka merawat hipertensi mereka. Kemudian yang berikut pertanyaannya adalah bagaimana secara sederhana kita bisa mengedukasi karena beberapa kali kami coba dengan menggunakan kader, menggunakan tokoh masyarakat dan itu masih belum bisa. Mereka masih seperti kayak ini apaan sih kalian ngomong-ngomong kayak gini. Toh definisi sakit menurut mereka adalah ketika mereka tidak bisa jalan dan mereka tidak bisa bekerja itu adalah sakit. Tetapi ketika masih demam-demam dan masih bisa bekerja, masih bisa ke kebun itu adalah sehat. Menurut mereka seperti itu. Dan itu sudah kita edukasi, tapi tidak bisa. Seperti itu.
Okay, that's the question. Yeah?
Yeah.
Okay, thank you, Angga. So before we go to the third question, I would like for Dr. Asri, no? For Laura and John. So Angga is questioning what is like the most feasible methods or approach to what is it to make health promotion, especially in mental health, can be delivered in areas with lack of access. He mentioned the comparison in Indonesia between Eastern and Western, which is he is from the Eastern of the country, which is do not have adequate the health access. So this is related to the inequality or presented, or maybe we can discuss about it. So we will invite the last question for the first term. I see one raising hand, please.
Okay, thank you, Prof. Herni, for the opportunity. My name is Tanti. I am a postgraduate student of University in Indonesia, community health nursing, and particularly I concern with occupational health. So I want give a question to Mr. John. I come from Ministry of Law, and we connected with employee in our correctional institution. So I just want to ask about how about data mental over the Manchester, especially from employee on a correctional institution. And can you share maybe have a program in a Manchester for our employee for employee over the correctional institute on Manchester, so I can make inspire our employee in Indonesia, especially in a correctional institution, because we connected with an inmate that they are who is have a problem people or break the rules and law. So our employee connected with and high risk with mental health in our institution. Thank you.
Yeah. So what's your name again? Sorry. Tanti. Okay, thank you, Tanti. So we already have 3 questions in the first term. And the first question is about, well, this is not quite related, but perhaps you have information about the career path in the forensic related to mental health, whether they have the foundation of the mental health or not to be able to pursue the studies in areas of mental health. If it is not really related, it's okay. If, yeah, it's okay.
So I'm not an expert about mental health nursing at all, so I don't think I can comment on the specific part. But one of the things that I wanted to highlight is that probably whatever path you take, you will not be unemployed, because I think we have seen. Hello. We have seen some statistics that have basically shown the shortage of staff, and that is also particularly true, I think, for the nursing profession and the distribution of nurses across different geographic areas in Indonesia. So I think that that'd be definitely opportunity, whatever path you would choose.
Yeah. Okay. Any addition, Asri?
Thank you, Laura. Yeah, I think that's a good question, and this is my question when I was graduated from medicine, right? What path should I choose? So I think that's a very good question. So based on the data that we have, both are good opportunities, but we can see that from the data that mental health burden is increasing, and then the mental health care, mental health nurse is still very rare, especially in the primary care. So we can see from Risnakas also that and Rifaskas is only very few mental health nurse is available in the primary care and also in hospital. So I think that's a good opportunity. About the forensic one, this is also a very good question that we actually never calculates the forensic nurse actually and the distribution in Indonesia. But I think that will be very few also forensic nurse, and the distribution is also not quite equal in all Indonesia. So I think both are very good opportunity.
Okay. Do you have any comment? It's okay if you think it's not really.
I mean, yeah, I'm not an expert in this field. I've done some work in the past on medical students and their choice of medical speciality. And a lot of that was them thinking about what they wanted for their job, what the outcomes were, and trying to match their preferences with what they felt a career in that speciality would involve. Lots of people placed high value on team working. And so they were after a job where they could work as part of a team. And that made them want to be work in primary care as opposed to in some other areas. So I think it's trying to understand the career path that you want and trying to match it to those jobs in the future as well. But I think, as others have said, I don't think there'll be a shortage. I think that there are shortages in those fields. So in terms of job security, I think that's not really an issue.
Yeah. Okay, thank you. So perhaps this mic is much better. Okay, so yeah, I think all of the speakers have given the about the career perspective in the UK related to forensic nursing. But back to your question, whether there is possibility that you are not mental health nurse at this moment and you want to pursue your study abroad, maybe in the UK, and then you want to check the forensic nursing. According to my own opinion, I think it's okay. Yeah, the moderator can also give opinion. Yeah, boleh ya. So there's open opportunity as long as when you apply, you have a strong argument, strong evidence that you can complete the study. You understand what you're studying to. Yeah. Okay, so I think that's the first question. Already remind about the time. So we go to the second question about, do you have any idea how what is the feasible approach to deliver like mental health promotion, especially we call it like in the urban areas with limited access, from your perspective?
Maybe I'll take just very quickly to say I'm not an expert again on the Indonesian setting, but I think this is an issue everywhere in different countries. That's also an issue in England, and it's an issue in two ways, in the sense that mental health services and promotion as well is not as strong and as available as maybe is the case for other physical health conditions. So it's the challenge of mental health itself. Other big challenge is the shift toward strengthening services, promotive services. And again, we can see that happening everywhere. One of the things that is key, especially where there are inequalities, I think, is the distribution of staff and human resources that can do that in first place. And then there are ways of maybe setting up payment and distribution of funding in a way that can encourage that. So I think there's also some pay for performance scheme, which is in place in Indonesia as well, that is specific for some conditions. I think maybe cardiovascular disease condition, where there is an incentive and there are some extra payment for some health facilities that make sure that the patient are checked and taken care of. So these type of payments alongside the allocation of core resources to be able to deliver the service can be helpful to also make sure that not only services are available, but reach the individuals that need those.
Yeah, thank you. Thank you, Mas Angga, for the question. I think that's a very good question. So addressing your question, I would like to reflect on our work both in the UK and Indonesia. In the UK, we also have similar problems, but with ethnic minorities. So as you know that in the UK, we have British South Asian, we have British Asian, we have several ethnic minorities. And it's a bit difficult also to give a health promotion and health prevention, or even to reduce the stigma on mental health for this population. So what we have done in the UK is that we work with the lived experience with the people with depression and anxiety from those ethnic minorities, and we have what we call PPIE, public and patient involvement in engagement. So when we create intervention, we need to always talk with them, not only when we already created the intervention, but in the process of creating the intervention itself. So, for example, if we would like to have a screening program or for mental health, we need to make sure that the question is actually addressing or related to their culture. So it needs to be with their culture. So when we would like to have a talking therapist, for example, and then when we design the step-by-step of the talking therapist itself, we have them in our side. So we talk with them in every single step when we create the intervention. And it is also well reflected in Stand Indonesia project, because we have what we call community engagement and involvement, in which in every single step, even when I analyze the secondary data, I communicated with the lived experience and the colleagues from the CEI. And then we talk about whether it is helpful, it is really reflect your condition. If not, what do you think we can improve for the process? And it is also reflected when we create LIPI, the low intensity psychosocial intervention. We work all Prof. Budi and Prof. Herni work together with the people. So it needs to be, intervention needs to be a culturally adapted and designed. So we could not just implementing the intervention directly to the people, but we need to also make sure that it is deliverable based or related with the culture. and of course work also with the available resources in the area. I hope it's.
Thank you, Mbak Asri. Any comment from John?
Yeah, I think they've mentioned most of it, but yeah, in places like Australia and in the UK as well, there are sometimes issues with getting health workers to work in more rural areas, and there's been various incentive programs, like Laura has mentioned, to encourage a more equitable distribution of health workers as well. So, and there are also, as Laura had in her presentation as well, about just having laws that require a certain amount of health workers to work in certain areas, but then you have issues about training and incentivizing people to move to areas where they may not want to be. So yeah, it's a complicated problem that's not unique to Indonesia. It's in many countries around the world as well.
Thank you. Angga, I hope this the one that has been, I would say, like the best practice from the UK and also some countries, to work with the service user, to work with the patient from the beginning. So that have reduced the stigma or the things that you mentioned that made difficult for the community to engage in the health promotion program for any level of activity, not only as the recipient of care, but also from designing the care, we already involve the patient. Yeah? Okay. All right. So the last question, I think, is directly goes to John, if I'm not mistaken, from Tanti. Yes. So the question is about whether you can share in the UK perspective about the occupation correctional institutions. Yeah. And this is related to the productivity discussion. Yeah, is it about prisoners?
Yes.
Mhm.
Okay.
Yeah.
Yeah, I mean, I don't have any I don't have knowledge of that now, but I'm happy to take that away and look further and provide some contacts if needed. But yeah, I don't really know about prisons, I'm afraid. Okay. Some answer.
Yeah, so thank you. This is a specific, very specific question, and I also never work with the prisoner. But at the University of Manchester, we have colleagues that working on that, and one of their project is called Engager project. So they have mental health talking therapies for the prisoner before, yeah. For the okay, for the employee there. Okay then. We will, yeah, I think I will go with John, and then, yeah, we will link you with the colleagues in the University of Manchester that work in the area.
Yeah, because for the prisoner, we have some program, but for the employee, to the keeper of the prisoner, it's I think in Indonesia, especially in the government institute, it's inadequate for concern in mental health of employee. Yes.
So yeah, I don't know any programs off the top of my head now, but I do know people who work in the prison sector, so I can find some additional information out if you want to provide your email address to me.
Yeah, thank you, Tanti. Yeah, I think it's okay, Juju. We can give one. I'm asking your permission for one term, another term, for the three questioners. Raise hand from the room first. Prof. Budi, yes, of course. One, Prof. Budi, second, and third. Okay, 3, 4 then. Yeah, one Prof. Budi and another one is gentleman from here. I will 3 at the back. Okay. Now I will give the last term here for more people. 1, 2, 3, 4, 5 then, yeah? Is that okay? Okay, can you please go directly to the question? Thank you, Prabhudeep.
Yes, thank you very much. I think today is like we are in Manchester University. Okay. For Mbak Asri, you explained about hypertension, and also in Indonesia is the highest prevalence for that. I tried to look at your PPT. I couldn't find the relation of hypertension and mental health problem. And instead, we find that the comorbid will be related to anxiety and depression. I think this is very important. It seems that no literature in the journal, the relation between that. So our finding, I think it is very important. The second one for Laura, I'm very interested about workforce distribution. Again, you only present psychiatrists and psychologists. That's why instant also we are moving to the community engagement, because the number of psychiatrists and psychologists is not enough to do the promotion and also prevention. My question is, how can we arise? How can we put on the data globally that community engagement, community leader as a cadre, as well as nurses always in the community. Yeah, even in the posyandu, pustu, and also puskesmas. Puskesmas is health center, and pustu is below health center. So I'm also couldn't find the information related to community engagement as well as nurses number who are doing this activity. The last one, Joe. It is very interesting, absenteeism and then presenteeism. I think presenteeism is very bad, isn't it? Because, but my question is, so we have to do something about their mental health before it happened. Do you have an idea for that? Maybe Lipi we will implement also on the workplace. Thank you very much.
Thank you, Prabhudeep. One person, three questions. But as I mentioned before, I give five opportunities, yeah, because this is a very rare moment. So we go to the gentleman first, yeah, who asked the second question. Oh, he's also gentleman. Okay. Yeah, Dr. Sigit, please.
Thank you, moderator, Professor Heni Susanti. I thought that there is a lot of quick question. Yeah. This is very interesting seminar. Yeah, and I have a new insight for the community problem, because I'm a community nurse, and every day, not every day, twice a week, I go to the community. Yeah. In terms of health, hypertension or diabetes, it is a local problem in our community. Yeah. I work as a RW, as a RTLW, and with our student, listen, my student as well. The problem on aggregate of adult who already work. Yeah. Actually, they have a high risk of hypertension. Sometimes they have a high prevalence of hypertension. But the problem is, it's difficulties to reach them. Yeah, it's difficult, and because what the reason is because busy, and I'm healthy and I'm strong and have to have earn money for our family, and have no time, something like that. But we really help them, to improve their health, to reduce hypertension and more control, something like that. And maybe you have any idea how we to reach aggregate adult aggregate in the community or in the work. Yeah, it is my first question. And the question is to Dr. Laura. Yeah, now I'm a member as a MKP, Ministry of Health, Kendali Mutu, in monitoring budget. in the BPJS center. And so many times I pursue to to have a suggestion that a nurse is have a more valuable to reduce cost health costs, yeah. Because like now more effort is to reduce from medical intervention, like what is tindakan palsu, fake, false, yeah, false, something like that, and phantom intervention like that. But I think the nursing is more valuable how to improve healthcare that can reduce our budget. Do you have any research that can approve that nursing is valuable to reduce cost and to make healthy, to make meaningful in healthcare for all people in Indonesia? Thank you.
Thank you, Dr. Sigit. So without going any further, we just go to Professor Hema first in the middle. Hello, dear. Oh, yeah. This is already go back, but that's okay then. You will get the turn. Okay, yeah.
Okay, thank you for the change. Good morning, everyone. I'm Haria Prima. I'm postgraduate student oncology nurses at Universitas Indonesia. Okay, I would like to give a question for Dr. John. Maybe based on the presentation about absenteeism and presenteeism, and especially their impact for mental health and then for the productivity or finance of the employees. So how can healthcare professional like us advocate for supportive about these policies to protect both employees and especially for their mental health and workplace productivity? Because as we know that still there are still some companies that force employees to keep working even when the employees are sick or unwell condition. I think that's all. Thank you.
Okay. Next, I think from the back there.
For the opportunity. My name is Nisrina, and I'm from undergraduate program here in this Faculty of Nursing. And my question is also directed into Dr. John. I found that presenteeism is indeed a growing concern among Indonesian workers, especially for young workers who just got into the working environment. And it is really correlated with stigma because mental health apparently isn't perceived as something important within our society. Workers who don't show up at work due to mental health reasons are often ignored and considered as merely an excuse. Even if at the end of your slides you already inserted the policy takeaways, which highlighted that Indonesian government is indeed must pay attention to this matter more. However, this might be a hard one to educate the policymakers regarding this matter because many of them still turn blind eye on mental health issues. And I would like to ask what is your opinion on this and what steps can we take to ensure that our concerns can be heard and hopefully there will be a shift in policy regarding mental health.
Thank you, Nisrina. Apologize if I'm asking you to question in Bahasa as well. Do you mind? Yeah. Yeah.
Okay. Mungkin saya mau nanya tentang kalau misalnya mental health itu kan di sini masih belum dilihat sebagai sesuatu yang penting, especially dalam dalam lingkup pemerintahan. Dan meskipun tadi di akhir slides itu sudah ada penjelasan bahwa rekomendasi selanjutnya adalah policy makers itu atau government itu harus mengimplementasikan polisi terkait dengan hal ini lebih jauh gitu. Tapi yang perlu diperhatikan adalah bahwa pemerintah di sini itu kan masih belum terlalu peduli sayangnya ya terkait dengan mental health. Dan bagaimana caranya biar suara kita bisa terdengar, bisa sampai ke pemerintahan, dan polisi ini atau kebijakan ini benar-benar bisa diimplementasikan untuk ensure bahwa well-being dari pekerja Indonesia itu bakal lebih baik lagi ke depan.
Okay, and you direct the question to John, you mentioned.
Yeah.
Or three of them.
Oh, boleh sih.
Okay, terima kasih, Ms. Sina. Yeah, I would like to restate the question. This is about how the government can help to support the policies. So at the end, the presentation is to point out the need for the policy support, but how to make this government aware about this issue. Maybe we can gather information from your perspective. Okay, last but not the least, from Prof. Hemo.
Thank you, Bu Santi. I'm Hema from University of Andalas. Thank you for the opportunity. This is very interesting topics of seminar. That's the main reason I want to attend directly to this occasion. For Dr. Asri, you present about the hypertension. It's similar to my research interest that I'm a nurse that have research interest in chronic disease, especially with diabetes mellitus. And then we find also that the cycle of the people with diabetes, they also can suffer from the mental health distress, depression, and then it will make the disease worse. I think it's very interesting that from your study, probably you can share with us, or especially about how can we moving forward with the condition, especially with the health system in Indonesia, that the mental health is not really there yet. And then also with Laura, I agree with Prof. Budi questions. In your study, I think you mentioned about the resource allocation, especially for the psychiatrists and psychologists. And meanwhile, we have more human resources, for example, from cadre or from the nurses itself, because you know that in the policy of our government, especially for the palliative care, the need of mental health nurses, especially in the primary health facilities, very needed. So probably you can share or provide some opinion. What about the nurses, especially with the mental health nurses? And for John, this is very interesting topic about absenteeism, dysfunctional presenteeism, especially you're talking about the mental health. I just wonder, this is very a good idea for the research itself, because the chronic disease, especially diabetes, they cause some disability, especially with the condition, and also will also influence the work productivity of the government, or the social or in private government. Thank you.
Thank you. So I think we have covered all of the people asking in the room. Just wondering whether there are also questions on the Zoom. Okay, good. Because we are quite limited time. So I would like to go one by one for the question. Yeah. The first question is from Budi, yeah? And that goes to all of the speakers. Mbak Asri related to the comorbid, any literature to relate the hypertension and mental health problems. And for Laura, whether there are also some data to exhibit the not only psychologists and psychiatrists, especially, of course, from the stand from our project, it's come up with other health workers Yeah, perhaps you are familiar with the cadres now, but we also have nurses, whether you can also dig information from somewhere else from the study related to the nursing workplace related to the topic. And for John, this is about how to how is it? How to integrate mental health in workplace. Okay. And then bring it close to your mouth.
Yeah, thank you. Uh, Thank you, Prof. Budi, and also Prof. Hema. Probably I will answer both of your question in the same because they are similar question. So yeah, we have actually studied or analyzed the data looking at linking between non-communicable diseases and mental health because they are very well connected. So from our analysis is those with hypertension, they have 1.7 higher odds of having mental health issues, which is depression. And then for those with diabetes is even higher, Prof. It is 1.93%. So almost twice higher odds of having depression. So I agree with you that yeah, we need to make sure that the people with the non-communicable diseases, including hypertension and diabetes, they can also be screened for mental health issues. There is a proposal like research that we are now actually also looking at. So we are looking at for integrated care. So because in Indonesia, we actually have fragmented care. So when people go to the primary care for non-communicable diseases and then that's it. Yeah. Even if they are referred to secondary care or hospital, and then we only give them one paper diagnosis and treatment. There is no indication about what the status of their health and their mental health and other things because it is all in the medical records and the medical record is not connected between each other. So this is make us more difficult to refer people and to the different specialties. And then that's why then we are looking at how to make this fragmented care into non-fragmented care. So make it can be interconnected between specialties or between different diseases. So this is what we are thinking to move forward to address this issue. So we need to make sure that the people, especially with non-communicable diseases, also can be screen or address for their mental health issues also.
Thank you, Mbak Asri, for the response. So this goes to Prof. Budi and Prof. Hema, yeah?
So we can comment that in the hospital, we assess also mental health.
Yes.
Don't wait till depression.
Yes.
Yeah, medical diagnosis, but we can screen and then, as I know also, if the patient stress or anxiety, the blood glucose also increase. So maybe one of our recommendation is please in the hospital or anywhere, the people who have non-communicable disease or also physical disease should assess the mental status.
Yeah, agree with that, Prof. Budi.
Further question for me, very short question, whether this is already available in the UK, the such integrated care or such integrated assessment.
Yeah, so in the UK, for example, yes, it is already available in the UK. So because we have mental health acts in the UK also and then it's then facilitating the screening and all for the people with depression and anxiety. And also in the UK, but I think we have now a new program also in Indonesia, Cek Kesehatan Gratis, CKG, the screening program by the government that the government give screening on the birthdays. PHQ4, yeah. I understand that the government screen it for PHQ4. And it is also available in the UK every year and then they will text me and then you need to get a screen for non-communicable diseases, and also there is some question on that also. So I think there's a good step, Prof, that we have PHQ for that cek kesehatan gratis. So at least exactly.
And
Exactly.
that would be another project of research.
Exactly. Yeah, this is what I'm saying about the yes. Yes, because in those people with hypertension. Yes, for those people with hypertension in Malang, we include the PHQ-9 and G87, the one that we got from LIPI,
Yeah.
to screen people with hypertension and diabetes there.
Okay. All right, thank you. I'm so sorry it should stop for you, and then next to the Laura's turn.
Yes, thank you for the question. And I think I'll take the one from Prof. Budi and Prof. Hema together because they're quite linked to each other. It is true that, anything that I've presented about the workforce is quite limited because really the workforce that we want to see better geographically distributed is the workforce in primary care. So I think mental health nurses or cadre are the first one to look at. We didn't have at that stage available data, but we still have 1 year of STAND project to work exactly on sustainability and scale up. So hopefully we can look a bit better into that. One of the things that were available in the data were maybe equivalent figures in Puskesmas. And even then we can see that the availability of staff was more equal across district because there are specific guidelines that require a certain number of staff for that. But I'm not aware whether there's anything similar for mental health nurses, for example. But still there were some inequalities, so some room for improvement. How to get to that stage? I think the answer is probably institutionalization that comes in different ways. It comes with a clear definition of what the roles of the cadres and the mental health nurses, define them as specific profile attached to providers at the lower level. It also comes maybe with some specific pay levels defined, which maybe are not well defined at this point. And it also comes alongside those definitions with a monitoring of their presence and their work. I wonder whether I should just take the question on.
Yeah.
So then I'll do it all at once because I think
Finish with your.
it's related. I think the question was whether there's any evidence that providing more care upstream, so in the community, might also be cost saving in a way. This is again a very big question, which is not only for Indonesia, not only for BPGS, but I think countries across the world are struggling. There is some evidence that might be cost savings, and some of the studies that show that are in the context of integrated care, and they show some potential cost saving for specific types of patients. So it's quite clear what the care pathway is and what happens if the interventions are taken more upstream. But one of the things to say is that we all tend to think that in terms of cost saving, but maybe we should think of that also in broader health benefits that having care in the community might have. So there might be multiple benefits for the patients that are not only not being hospitalized, which is a lower cost. So I think it's about taking a different perspective. And the last point that I wanted to say is that is also thinking maybe about different types of care in the community. So some of the evidence that we have, I think, in the UK is related to care in the community for all the patients that are discharged from hospital. So if you think about the cost, the evidence that is quite related to the fact that if you take a patient out of hospital and you provide some care at home, the cost is less. But maybe this is not necessarily the type of community care that we are thinking of in terms of promotion. So maybe we should differentiate a bit more when we think about those options.
Yeah.
Your area is related to financing, isn't it? If the psychiatrist and psychologist study, it takes time, And then we are worried also whether they want to work in the village. But the cadre is there, and then we can train based on our stand. We know the budget to train them. And then the nurse also already there, so we can empower them. So, but in article or in journal, never saying that.
Yeah. Nara, you want to give comment and then I will give a little bit.
Yeah, I think the cost of how to provide health provider related to mental.
Yes, I think the points of providing in the community with workers that are that comes locally and are motivated to stay there is a fair one. And I think, as John was pointing out, has been studied maybe also in other setting with reference to some remote areas. So it's not only about maybe giving some incentives, but maybe about recruiting and training in first place some staff that is motivated to stay there. And the other point maybe to make is that if we think about the organization of services, we maybe don't really need psychologists and psychiatrists for everyone. So I think it's fine for this type of services maybe to be concentrated in some higher level facilities. But there's definitely a lot of work to do. And I think that there's not lots of evidence already published.
Okay, John, you go on.
Okay, thanks for the question. So I think it was presenteeism and absenteeism, sort of bad outcomes linked to mental health, and how can we promote mental health in the workplace? And I think this kind of touches on the following question as well. So what can we do to promote mental health? And I think that depends on what the workplace is. So we were talking about very, very different types of workplaces in the study that I presented. You had the more formal work, sort of offices with government workers, university workers, contracted workers, and then the informal workforce as well. So if I think about my own workplace, we have lots of awareness campaigns, posters on walls to encourage mental health, reduce the stigma, encourage us to eat healthy and exercise and sleep, I think are the ones that I can remember. And there are training programs as well to encourage mental health. But that's in the context of working in a large organization, in an office, not as a self-employed worker who has no real sort of training options or things like that open to them. So I think it's quite a difficult question that will depend on the workplace. And I think probably where the informal workers are concerned, it will be a government issue to promote to those types of workers, whereas for the more formal workers and contracted workers, it would be workplace promotions and awareness campaigns and allowing them the flexibility to take time off if they're unwell. Although absenteeism is a bad outcome as well. You don't want people ill and you don't want them losing work because they are ill. So it's the illness that's the problem. There has been research that suggests that taking those short time periods off work because you are ill allows you to recover a bit, and it reduces the long-term impact of prolonged presenteeism, prolonged periods of reduced capacity at work.
Yeah, thank you, John. I think you also have addressed other question, yeah?
Yeah, I think that kind of linked to three different questions.
About the support employee with
Yeah.
citizen already mentioned, and also a little bit for the policy support or government support question from Ms. Rina. Have we missed the question that have been asked from Dr. Sigit and also the others? Huh?
Yeah.
Okay.
Yeah.
Yeah. Mhm.
Yeah, we have a question from Dr. Sigit about how to reach people who work with the NCT screening. So I would like to share our experience with our NCT screening in Malang. So at first, when we rolled the screening program, 80% are women, the one who attending, because they're the one who is at home, and then there's the one who go to the posyandu and while bringing children or grandchildren, and then they got screened. And then we then try to figure out how then we reach the people who are working, especially men. And then there are two type of intervention that we give. The first one is we reach them through the activities that they do at home. For example, like if they go to mosque in the evening for Salat Isya, for example, and then we then approach them in the event. This is one of the example. So because there is always a pengajian afterwards, and then we then approach religious leader whether we can enroll during or after praying or pengajian. This is the first one. But still we could not reach everybody. And then we have the screening program in the offices. So yeah, in the offices. So for example, we go to the Bapeda office. We go to the offices that we can then enroll in the offices. The third one is we use the wives. So we approach the wife and then we say to the wife, if it will be good if your husband can attend it the screening program, because usually what we got sometimes we got bapak-bapak takutnya sama istrinya, what we got the husband
ikatan
suami takut istri ya. So we say that usually husband like very obedience to the wife, so we approach the wife. Yeah, exactly.
Power of women, yeah?
The power of women. We approach the wife and we say that will be good if your husband can be screened. It will be good if he knows earlier rather than later if they have non-communicable diseases. Yeah, those are approach that we have done in our screening program.
Yeah, okay. Any more? Or you just everything has been responded or answered, yeah? Or you want to add? Okay. Okay. Yeah, I think all of the question has been addressed, yeah, for the five questioners, yeah. So I think it's about the time to close this seminar session. Please allow me to give a summary about our seminar today. Three speakers have presented their topics, which is very important, and they are not from nursing. They are from epidemiology, physician. They are from health economics. In this event, we discuss about the health sectors, especially mental health, from their perspective. And the discussion arose from how this mental health has been influenced by many factors. And most of the question is about how to, and this maybe from the speaker's perspective, this is quite challenging as well, because most of our speakers are from the health economics. But this is also reflect how the audience really want to know, and also want to understand as the take-home message what is actually the further action from this seminar. One of the issues raised by some people question is about how the nursing especially, can be more acknowledged their roles in the health service, yeah, reflecting what's going on has been in the UK, yeah, and one of the promising activity that we are doing now, especially in STAN, yeah, we are trying to emphasize that what is the meaning of health workers, especially mental health workers, also include nurses and cadres. So this is also perhaps what you've been learning during our STAN process. Well, in the population itself, nurses has a big portion in the health workforce. So I think this is the home message that perhaps in our small, no, it's not really small, it's a big project, that this acknowledgement of other mental health workforce, especially cadres and nurses, can be lived up. Or it doesn't mean minimizing that. Of course, this is to help. This is to work together side by psychologists, psychiatrists, providing that their number are also limited. And the good news about this project is the question from one of the person here, how the government can support. We are going to have tomorrow, we're going to have workshop that involve some policymakers related to mental health project, especially depression and anxiety. So perhaps from the workshop, we can also raise this issue about the involvement of a variety of workforce and also about the integration physical health to mental health and others. So this is like small steps from us, which we believe there are many approaches have been done by many people in Indonesia. So I think that is the take-home message that we are bringing today. Yeah, and another message is I would invite all of the audience, online or offline, based on what we have doing since this morning. There are lots of ideas of research, further research to be explored in our context. Absenteeism, productivism, inequality, something that is underexplored in our context. So this is a call how we benefit from attending this event. We give applause again for our speakers. Massive gratitude, massive thank you for all of your presence and also sharing. So please allow us to go down and then sit down at that side. Okay, thank you very much.
Yeah. Please give applause, everyone. Thank you very much, Professor Herni Susanti and Dr. Aksri, Dr. Lauren, and Dr. John for the fruitful insight. Okay. So the next agenda would be documentation and then giving the souvenirs by the chairperson of NTC. So maybe we call Dr. Sigit Mulyono to take over the floor, and then maybe for the three speakers, you can go to the stage because, yeah, it's okay. And the documentation, the Prof. Budi too, maybe, yeah, we give the souvenir. Yeah, you can stand here in the middle of the stage. So the first maybe would be Prof. Budi, second Dr. Sigit. And Dr. Girmansyah. Okay. Please welcome Dr. Irwansyah to in front of the stage for giving the souvenir. Okay.
Thank you very much.
Yeah.
We will take photo together in front of the stage. Okay, 1, 2, 3. Smile. Okay. Okay, 1, 2, 3. Any style? Other style? MU? Manchester University? How? Manchester, Manchester University. Okay. Okay. Okay, and UI, Universitas Indonesia, UI, UNI. Oh, okay, all of the audience, please go to the, oh, yeah. Please, everyone stand and go up to the stage. Okay, let's everyone take photo together.
Yang lainnya di atas. Kursinya digeser.
Okay, everyone is set up? Okay, not yet. Wait for those. Okay, okay. Okay, I will count down. 1, 2, 3.